We see you live.
Good.
And there you are. I see Dr. Nitin Barman and Dr. Kini, and of course Dr. Sharma. And I love your caps. Nice, colorful caps. Welcome. Very, very excited. Let's get started. Everyone seated in the dais, and let's move forward with our first case presentation.
Okay. Yeah. Beautiful. Welcome everyone, and Anu will start the case now.
Yeah, good morning everybody. If you can see the case number 1, before we start, as you mentioned, you see myself and Nitin Barman will be the operator. We have our 2 fellows who is here, Mohammed and Neeraj, and the entire cath lab staff with us. So this patient actually presented to the outside cardiologist who first time presentation with the recent onset of angina and heart failure symptoms, and that's how everything was diagnosed. So he has pre-diabetes, hypertension, dyslipidemia, and prior CAD with the known RCA stent in 2003, and then was lost for follow-up. So the recent tests showed that he had markedly decreased functional capacity during the stress test, and the echo had shown that he had a globally low EF of 20%. During the stress test, diffuse ST depression and echo showed that he had multiple regional wall motion abnormalities. He was started on appropriate therapy, and rightly so sent for cardiac cath to rule out any CAD. So this is where we are with his angiogram. So the plan was that he would, I'll show you the angiogram first. The right coronary artery.
LV first.
Yeah. Totally occluded.
Wow.
Severe LV.
Yeah.
Pretty bad LV.
Yeah.
So he has an EDP of 36 today, despite on medication. And this is where we are. You have this left main. We are talking about moderate 60% disease, significant disease of this large bifurcating OM, which we actually call OM1, OM2, with moderate calcium, as well as significant disease of his, this is the caudal picture of the left main, but more important of the LAD, maybe 50-60 LAD, but significant disease of the diagonal.
Wow. Incredible case, difficult, 3-vessel disease. First question, as everyone's getting mic'd up, so only half of our panel can speak. That might be a good thing.
Why?
No. We have an amazing panel, and it looks so nice here. They're all very relaxed, almost like they're sitting in their living room. It's wonderful.
Well, we are trying this one.
But before we go, I mean, first
everybody
question.
Everybody should have the mic. Good. So I mean, this case is a heart team discussion. We are going.
Heart team discussion. Yeah.
Heart team discussion, and at that time what happened is CTS had refused bypass mainly because of the EF that was so poor. So the plan today was Impella guided PCI on this case. Definitely we are not going to do the right coronary artery. So this is where we were with the bifurcation circumflex. We did PTCA of the main branch, followed by, our plan was to do a cutting balloon, and we know when you have that moderate calcium, Wolverine or any kind of cutting balloon is not going to make a turn. We pre-dilated with the compliant balloon followed by Wolverine, and then we did a stent across here, which is, that's where we are.
So it's sort of like, it's a bifurcation lesion that you basically use the Wolverine, the new cutting balloon of Boston Scientific, and you went across. I think very important, just I see the Impella guidance. I know that you don't want to spend too much time because we've got a lot of other cases going, but we have John LaSala. Anyone here would actually attempt this kind of a case without support? Please, Paul, would you do this without support? Do you not have? Oh, he doesn't have. Yeah, so Paul is questionable about the support, but the majority here would say that support is definitive. I think going forward on the, as far as, and it looks like you just did a single stent technique. Viability is the other question for the LV. When you see an LV like that, obviously there must have been some viability in this. That's why you're proceeding with this complex intervention. Is that correct, Dr. Sharma?
No, in this case, actually, a patient had a stress echo. Didn't have any MRI. The other patient had MRI, but this case had just stress echo, and they had a wall motion abnormality augmentation, as well as a dyskinesis in that area. So therefore, everybody felt that this is a viable myocardium And in this particular case, we did not do the MRI. Patient was referred from outside. So we don't have the MRI, as you rightly pointed out, that viability MRI has become the gold standard. And particularly when the surgeons are taking these patients, they want to make sure that the tissue myocardium is viable before they take it. So in this particular case, we didn't go that level. But again, as I said, the patient is very symptomatic and positive wall motion abnormality. So with that note, Anu has a plan now. What do you want to do now, AK?
No, going back to the question whether we need LV support or no, I would go that in this particular guy who has such severe LV dysfunction, echo, I think, showed some mild to moderate MR, but more important is his EDP. When you have a EDP 36 and you are doing multivessel PCI, invariably there's likelihood that if you go, your PCI is going as planned, you'll come out fine, but if there is anything that goes wrong during PCI, that this guy will go into flash pulmonary edema on the table requiring intubation. So I think since the EDP is high, I would definitely say in this case, support with Impella is very important.
Antonio has a comment, and I'd like to hear from Raj Makkar as well. Antonio?
The side branch originating from the bifurcation, I think is giving collaterals to the right coronary. So I may be a little bit more aggressive. I would dilate through the side branch, and we usually, if we have a reasonable result, we do drug-eluting balloon on the side branch. I know it's a small side branch, but nowadays with the Impella support, you really can afford to do something more. It's not critical, but I think it's...
I think also in preparation for your future plan, I know, Anu, that you're bringing this patient back for the right coronary at some point to do, and I think it's not a bad idea to make sure that your highways to the right coronary, the retrograde highways, are well taken care of. Raj Makkar, did you have a comment? I see you leaning.
I agree in terms of using Impella. I think it's prudent. I think it gives you all the time that you need to take care of everything very meticulously. In this case, and I also agree with Antonio that we need to fix all the other branches. There are 2 branches there, and in somebody whose EF is really low, I think it's, and you have the Impella, I think it's the appropriate thing to actually go after those branches and fix them too. I'm curious about the left main. I'd like to know more about this.
Yeah, so that's the big plan for
by
yes.
FFR to understand, whether or not this is actually truly, because that changes how you're going to approach this.
Well, that's perfect segue to, I think, the plan for the left main. Anu, are you going to do anything to that side branch of the circ?
I mean, we can do it later on. Right now, we sent it across. Like we said, it was hanging by the rope. It's hanging by the thread. So far, so good. So I think we'll leave it alone. We'll move on to the left main LED, what we had discussed. And an interesting point, we were also discussing, do we go the imaging route or do we go the physiological route? We chose the imaging route, and we just want to show the optical coherence tomography as a part of imaging role of that in, lesions like this, which is actually bifurcation. If you see here, LED diagonal, which we had shown you there. So if you can see here, you're in the back.
Yeah,
we didn't take too many pictures. Same, though the creatinine is normal, we didn't want to use a lot of dye. So this is where we are.
Yeah, so we have a couple of comments before you move forward. I think evaluation of the left main, many probably on this panel. I mean, physiology, Dr. Sharma, you gave a beautiful lecture, by the way. I want those slides. Excellent lecture this morning. But your top #1 advance this last year is the use of physiology in our armamentarium. But I think in the left main is different. Chet, you had a comment, and Antonio Colombo.
Yeah, just a question for my colleagues here. There's a whole range of how people approach these cases. Like Paul was saying, you might not use any support device. Am I the only one thinking I might use tandem heart, intubate the patient beforehand, and do everything in one sitting? I'd get my retrograde colleagues all lined up, ready to go as well.
Yeah.
I would like to do everything at once in one go.
So you hear that? Dr. Chet Rihal is saying intubate the patient, tandem heart, everything in one setting. I would be a little bit against that just because I care about the kidneys. as well, and I'm worried about too much dye. Although they didn't use much dye here. We just saw that. They did a really good job with very little dye. Yes, Chad?
So it's very interesting when you look at the creatinine after those type of procedures often goes down because of the higher flow during the procedure.
That's right, the better flow. And I think the Impella work has shown the same.
I would do just the opposite. I would do this radially and do the circ. I'm not clear there's a lesion in the left vein in there.
Well, that's what we're going to find out.
Do some IFR, FFR. And then there's a right. How old is the patient? I missed that.
No, we will do the imaging first, and if really there is question, we will get ready with the FFR. I just wanted to do the OCT here from the left vein all the way to the LAD, and just to tell you that we did do an app about this imaging modality, and it is available free. We are going to release it today. Everybody can go and check on the app store called Octade. They're going to show it on the side that you can download this. A team of physicians from here, Mount Sinai, along with Mount Sinai App Lab did it, and it was coded from India by the Viba Technologies. Please download it, and you can then go step by step how to do OCT.
I think you're going to hear today over and over again this work that Dr. Kini is doing is in coming up with applications, apps that anyone can use anywhere around the world with sort of aiding the interventionalist in moving forward and following the steps that are incredibly important. This particular OCT app, we're gonna hear about it a little bit, I think is very, very useful. It's not gonna be something, I think there's futuristic thoughts about this, incorporating it into the case that you're doing, but this app is very, very interesting. So are you gonna show us the app, or are you gonna show us this particular
app you have to download, you'll see it.
Okay.
Just go there to the App Store, Octade.
OCT,
you download and start
and
using it on your iPhone right now.
Roberto already has it, yeah. Roberto has already got it on his.
Yes,
Yeah.
What is it called?
So it's OCT8, Octade. Yeah.
Octade.
I mean, there's several ones. There's one for transeptal, there's a bifurcate, there's all of them. So tell us, why are you doing these apps? I mean, everyone is saying, why?
Yeah.
You know, what are we supposed to just follow how you do things?
Yeah, no, it's just for more important is how things are changing. Right now, everybody is sitting in the classroom, sitting in the lectures and seminars in the classroom. Like we said earlier, we could be in Central Park and using our smartphones and going through this learning technology outside. You don't have to be in the classroom. So it is basically smartphone, web-based, and social media. Everybody is on the social media, especially people like you.
So thanks a lot.
Facebook, Twitter, I mean, you name it, everybody is on that now. Nobody is opening the books anymore. So interactive illustration and more important, animations. You can show exactly how you do the technique. You can use animation. That was the goal when we did our bifurcation.
And I love that she's developed actually a venue where you could send in your OCT image and have it expertly evaluated by our team here, our imaging team. We built a very, very strong imaging team, one of the top core labs for OCT and imaging with Dr. Narula here and Dr. Kini, and we've set up a very, very highly technical venue, and I think that to me is very exciting. And then the idea of incorporating that and Bluetoothing that into your procedure is going to be very important. So show us what this. Can you show us? Take us through the
other
OCT.
thing also is easy update. Suppose you have a book and you want to update. Write a new textbook again. Minimum 2 to 3 years you'll need it. These updates are very easy. Within weeks you can update when you have any conferences and new things come up immediately.
No, I think there's no question this is the next wave of
and
how
the next
education
step would be the virtual experience that we can use the iPhone and understand exactly how to do the technique and use artificial intelligence after that.
No, there's no question.
Depending on how many times the app is being used, we can see who are the users, understand how to get artificial intelligence into this thing. So now we are doing.
Okay, let's show us the run first and show us how you're incorporating OCT into your planning or even diagnosing.
Co-registration means you know exactly where the OCT. See that? Right now coming back. Now go back. I want to see left main. What was the left main?
Look at the LED area at the bifurcation, then left
Told
main.
them, first left main. How much is it we are getting? 7.5?
That's what it turns out. That's the way they become.
Well, I can tell you the angiographically today, compared to the last time when we have the film, it looked much better. Whatever the region was, clearly was 60-70% angiographic, and this is the type of case. Now, only question will come, patient has Impella, we are going to FFR, but the question
Okay,
is,
now
with
go
the
to
Impella, what
LED
does
diag.
FFR means.
Go to the LED diag and show us the 3D reconstruction there. No, go to LED diag. What is the cross-sectional area of the LED at the level of the diag? There's the diag right there, right?
Ostium is no disease.
No. It's not. We look at it. Look at the 3D. Look.
Looks very fancy.
That is the opening.
No, I think the 3D reconstruction really does help in understanding where,
What is your
you know, where the lesion is, what the
osseous.
ostia look like, what kind of what's great about the current algorithms that they now have in these FFR, in these OCTs, is the ability to actually, it actually is like basically OCT for dummies. It really figures out everything.
Well, I think
Yes, Eberhard?
everybody
just one
wanted,
brief comment what he just said.
Dr. Grube?
And we all laughed about it. It looks fancy. You know, when you have these imaging
do that
techniques,
thing.
you all have to ask yourself, what does it really mean, and what can we do? What can we take
Exactly.
out of it? Does it change anything, or is it just fancy to look at?
No,
That's
do
right.
it.
And I think that's very, very important to see that, how are you incorporating what
Yeah.
you're seeing on OCT as opposed to, you know, the patient's symptoms and everything else. Antonio, did you have a comment?
You know, you see all these things only during meetings and not in real life.
Why?
The other point is the old rule is that you make your decision up front. If you want to treat, in general, you go for imaging. If you don't want to treat, you go for FFR.
Oh, yeah.
But in
That's
this case,
that's an
no, but
interesting
Antonio,
concept.
That's a very good point, but in this case, imaging didn't help us.
Yeah,
No, he's saying go ahead. Oh.
yeah.
All right, start the drug.
Mark,
Okay,
is-
right,
We are with the
resting
FFR now.
0.9.
Resting is 0.93.
Mark Reisman, you have a comment on the imaging?
I think the OCT has been very helpful here, and it looks like it's not very significant. But
Your other wire has
Yeah,
come out.
I think so. And I think that before, everyone was looking at the angiogram, well, this looks good, why do we even have to image it? But I do think that in a patient like this with 3-vessel disease, poor LV, you're seeing, and honestly, the films we reviewed before coming in here, it really does look much better than it did when we looked at it
So-
together, Dr. Sharma.
And not only that, this patient was supposed to go for surgery.
Yeah.
Patient has a surgical consultation.
So,
Right.
Roxana.
Yes,
Now with this information, how
going
do you
with
feel
the
about the
adenosine?
Impella?
yeah. That's a good question.
That was sort of my point. This looked to me like a circ lesion you do quickly, and if you want to do the right as a CTO, you probably bring them back for that. Different.
Okay, go.
Do it all radially.
Yeah, and I think honestly, before the live case, we reviewed
All right,
every one of
here.
these
Okay,
films.
0.8,
This looked worse.
0.
Yeah,
Good.
okay, FFR is positive.
Show the FFR, guys. Yeah.
Good, stop, adenosine.
So where was it?
0.78.
So where are you going to do a pullback?
Put the FFR wire.
Yeah, I think it'll be great to actually have a pullback and see where you...
Yeah, do you want to do a
Okay,
pullback?
we are at
as-
the pullback here.
And it
This is
also
the
may be
proximal
slightly
after the left
misleading
main.
because you've
0.85.
got the right that's being filled, so your overall territory is extensive, and you're planning
All
on
combination.
That's not-
revasculating the right. That may be
multiple lesions.
Wow.
So it basically still signifies that the left main and all these cumulative lesions are significant.
Well, I think I would rely more heavily on an IFR if you're going to make that determination. This way, you could, when you do the pullback, you could see exactly where the
Where
incremental
the
differences are.
step up is,
It'll
yeah.
allow you to quantitate what's related to the LED and what's related to the left main.
Okay.
Well, there's no question that the diag needs to be done.
Yeah.
And
Now,
then
can
I
you,
think
in the
after,
3D,
you can take a
reconstruction,
look.
Could we see any disease in the diag?
No, but it's further down. Now, question is
Would you have done, who would do this radially? It looks like, for sure, 3 or 4 people would, 5 people here would do this radially, Dr. Kini. What are you doing? I mean, Nitin Barman is there. He's saying, why aren't we doing this radially?
Okay.
I don't know, ask the panel how many people will do radio.
Many said,
Half and half.
radially.
You should have told me beforehand. I would not have pulled it off.
Okay.
Yeah.
But I think I would agree also with Paul that the whole complexion of
Take
the
a deep
case
breath.
changes. If you're not looking at the main body of the LED
Ready,
and left
right?
main as being
Ready?
areas you have to intervene on.
Deep
Now
breath.
you're looking at a side branch diagonal, a major marginal, which is significant, and then, you know, a right that can be staged or done at the same time, depending upon the
Yeah.
amount of
So-
time and effort it takes.
So your plan now is to treat the diagonal and probably, are you going to stent across, left
That was
main
the
across?
question. Do we need to do bifurcation LED diagonal? Ostium is involved. I would do bifurcation there. Because if you put a short stent in the diag and then stent across in the LED, definitely will start looking worse later. What does the panel think?
What does the panel think, well, based on what we just saw? Let's start with Paul. Paul, how?
I have to see it. I have to see it again. I mean, give me a working view.
Show one more
Can you
time.
show him a working
Where's-
view of the LED diag, left main? Yeah.
Okay, this is the working view for us, right? You tell me the
Can
view.
you show us
Yeah, we
an
need the
angio?
Contrast stuff.
Contrast in there would help.
Good.
There we go.
So there's a lesion in the diagonal. I assume that's the diagonal, right?
Yeah, there's
High
definitely a
diagonal.
lesion there that needs
don't
to
we
be
just put a
treated. The
stent in
question
there?
is what to do with the left main, LED,
So, and the FFR was abnormal across the...
across the
Across,
left
cumulative
main
across, and I
LED.
think that was a
Across the
gradient
left
at the
main or
pullback
across the
also.
diagonal?
Across the diagonal.
It was across the LAD, not the left main.
Across the LED down
And
into the
left main.
diag. You know,
When
into the
when we
ostium of the
pulled
diag.
it back to the proximal LED, we had an FFR from 0.77 to 0.86. So
All right, so it's just an LAD diagonal bifurcation, right? Is that correct? Am I-
That's what I think it looks like, because the left main looks
Okay.
fine by OCT.
yeah,
Okay, so you could use any one of the bifurcation techniques you want here. You can do, you're going to use 2 stents because you just decided that the LAD needs to be stented, and that diagonal clears to be really needs to be stented. So what would I do here? I would probably do they're nice and big. You can do a culotte, double kiss.
Is there a lesion in the LED? I don't know.
Well, they say there's a lesion. I don't see the lesion in LED, but I'm told that there's FFR positive lesion right across the diagonal in
Yeah.
the LED, correct? And we can
Yes.
see it, I don't know, how big was it by imaging with the OCT?
which one the?
You're going to give us all the data.
Pretty big to me. So that's a little confusing to me.
So there's a lesion in the LED right at the bifurcation, is that right?
Okay, give the diagonals.
If there is one, then you got to do bifurcation. If not, just put a stent in the diagonal and then
Diagonal, right.
do your right coronary or not.
So can we see the OCT run again, please, and show us exactly where you are and where you're seeing? What we want to know is the diagonal severely diseased? The ostium of the diagonal, and it didn't look severe, but the OCT, but the FFR was positive across the LAD into the diagonal. Is that
Okay,
correct?
see that? That is exactly where the ostium of the diag is. You see
Okay,
that now?
what did you get for an MLA there? For an
And what did you get for, yeah?
You get the MLA at the LAD at that level is like 4.7.
4.7 is pretty big.
Not bad.
That's pretty big, and the FFR, you said, maybe you should do the FFR again. It changes.
Yeah, I think after you open this lesion in the diag, I would.
No, why would we FFR the LED after opening the diag?
No. When you're going across, I mean, are you planning to stent? You're stenting across with a dual stent across, right? I mean, to me, I don't know where you're seeing the issue of the lesion. Is the lesion in the diagonal or in the ostium of the in the LAD or in the ostium of the diagonal?
No, it is not. It is in the LED. Based on the FFR, it is the LED.
Okay.
Now, if you go with imaging, okay, if you go with imaging, at the level of the LED is 4.7 there, okay, 4.7. And
So that's
at
large,
the
right?
bifurcation, you
Roxana,
definitely see the ostium of the diag is involved. Although you really want to understand how bad the osteal disease is, we have to do the OCT of the diagonal.
I think
don't want
the LED has diffuse disease, and that's the reason why the FFR is low. I don't really see a discrete lesion.
No.
I mean, you can stent long the whole LED and maybe
Tell me,
get
what
the
would you do here?
FFR a little
All right.
bit
What would you
better.
do here?
Why
What
don't
would
we
you do?
let you guys work on this? We're going to go to lab 3 if you're okay, Dr. Kini. We'll come back. We need you to, when we come back to you, lay out to us what kind of luminal diameters and what FFR numbers you got across the LAD and what your plan is, and then show us the final result.
Okay.
Great. Excellent. Very great case.
Ready for
Let's
the
go
third
back
case.
to room 2. Room 2, Dr. Kini, show us what you did.
Yeah, so actually what we did was same mini crush technique using LED diagonal. That technique, I think we just went through the app in the other room, so we'll not go over it again, but did FFR of the LED. So it was 0.92 when we redid the FFR, and then we did the pullback. You see there? You can see the pullback, what we are showing, that at that level, that means it was 0.99, right? 0.99. Essentially saying left main, you don't have to do anything.
Yeah,
you
so
can
the
leave it.
left main is fine, but before
final
the
picture
LAD was severely diseased by
And this is,
FFR.
yeah,
They
this
did
is the final
mini
picture of,
crush. You abutted the stent into that diagonal, right?
Yes, yes.
Yeah, so
Yes.
there's no space there. So it really is a long 2 stents in the diagonal with a
And this
mini
is where we
crush
are with the
into
final
LAD.
picture. Look at the circ, looks good. LED diagonal. So essentially 3 stents, and our total dye use was 170.
Yeah, so let's give her a rest, or him a rest, 67 years old, and you'll tell us maybe how the right goes. Maybe you'll do that as a live case, Dr. Kini. Thank
Okay,
you.
thank you.
Thank you so much. Thank you.